this lecture, you will be learning about the high-risk pregnancy. There are factors associated to a high-risk pregnancy that can be pre-pregnancy issues or factors that are brought on by the pregnancy and related to the pregnancy itself. We'll be discussing both of these. We will begin our discussion of the high-risk pregnancy talking about pre-gestational problems. So the majority of these problems start prior to a woman becoming pregnant, and these can make her pregnancy additionally high risk. Let's review the definition of diabetes mellitus and how carbohydrates are broken down and what the role of insulin is. This will probably be a review for many of you. Diabetes mellitus is an endocrine disorder, and it involves inadequate insulin and then can affect blood sugar levels. As a review, carbohydrates are eaten, and they're broken down into glucose. The pancreas produces insulin, and this allows that glucose to be stored as glycogen. Glucagon then stimulates the breakdown of glycogen when blood sugar levels get low into glucose again, and then this can be used by the cells. This is the normal process. However, when there's insufficient insulin, the glucose remains in the bloodstream. So what kind of blood sugar levels do we expect patients with diabetes mellitus to have? That is, absent of any kind of treatment for it. We expect them to have high blood sugar levels because there is a disorder involving the insulin. In order to understand how the implications of diabetes mellitus are augmented by pregnancy, it's important to understand normal carbohydrate metabolism within the normal pregnancy. Early in pregnancy, hormones, including progesterone and estrogen, increase stimulation of insulin production and increase tissue response to insulin. So what kind of blood sugar levels do you expect if there's more insulin being produced and if the tissue is more responsive to it? We would expect to see lower blood sugars in early pregnancy. During the second half of pregnancy, however, there's a state of hyperglycemia. In addition, there is resistance to insulin. This is due to the placental secretion of human placental lactogen, prolactin, and cortisol. So what do you expect to see during the second half of pregnancy if there's hyperglycemia and the tissues are resistant to insulin? Typically, we'd expect to see a little bit higher levels of glucose. Why is this? Well, this is a protective mechanism to allow for more blood sugar in the bloodstream that can cross the placenta so that the fetus can get the glucose. So if there are already problems related to diabetes mellitus prior to pregnancy, that can really be compounded because these changes are seen even in the normal pregnancy. So certainly having any kind of endocrine problem related to insulin or diabetes can be compounded further. Gestational diabetes mellitus is when a woman is diagnosed with diabetes mellitus when she is pregnant. What causes this? Well, it can be caused by the pregnancy and changes associated with it, or it can be a pre-existing disease that went undiagnosed. If the pregnancy is causing it, it can be a compensation of a metabolic abnormality that was added to by the stress of the pregnancy, or it can be as a consequence of altered maternal metabolism resulting from the changes in hormones related to the pregnancy. Will this woman be a diabetic for the rest of her life? Well, between 15 and 50% of women who are diagnosed with gestational diabetes mellitus will progress to type 2 diabetes mellitus, adult onset diabetes mellitus if you'll recall, later on in life. During pregnancy, we screen all pregnant women at 28 weeks gestation as part of their well OB care. If you think back to the normal healthy pregnancy lecture, we do a 1-hour glucose tolerance test with 50 grams of oral glucose, that glucola that I talked about, and the normal for this is about 135 to 140 milligrams per deciliter. If it's higher than this, I mentioned we would do a 3-hour glucose tolerance test. Now it's time for the explanation of the 3-hour glucose tolerance test. So in a patient who we suspect it might be a gestational diabetic. They have a higher blood sugar level than 135 to 140 milligrams per deciliter in their 1 hour glucose tolerance test. We now do a 3 hour. This time we gave them 100 grams of oral glucose. Prior to this, we'll get a fasting blood glucose level. After they drink it, we will check their blood glucose levels at 1 hour, 2 hours, and 3 hours. So, if their fasting glucose level is greater than or equal to 95, if their 1 hour is greater than or equal to 180, if their 2 hour is greater than or equal to 155, or if their 3 hour is greater than or equal to 140 milligrams per deciliter, we would be suspicious. How do we make the diagnosis of gestational diabetes? The physician would do this based on these lab values. There must be 2 abnormal lab values, values that meet or exceed these numbers in order for the patient to be diagnosed with gestational diabetes. So with the 3 hour glucose tolerance test, if she has a fasting 1 hour, 2 hour, 3 hour, if she has 2 of these tests that are higher than or equal to the numbers that I mentioned and the numbers that are stated here on the slide, she will have the diagnosis of gestational diabetes. Diabetes can affect both the mother and the developing fetus. As far as maternal implications are concerned, first we'll discuss ketoacidosis. Hyperglycemia due to low amounts of insulin can lead to ketoacidosis. And this is when there's an increase in ketone bodies in the blood released when fatty acids are metabolized. In addition, when we have high blood sugar levels, the blood can kind of settle in the vasculature. This can cause vascular disease. As far as kidney function is concerned, this can cause nephropathy because of the settling sugars and increased blood sugar levels. It can cause an increase in retinopathy, where the blood sugar can settle in the microvasculature of the eyes and retina. In addition, this can cause hydramnios, or increased amniotic fluid levels. Why would this be? Well, if you'll recall way back in an explanation of diabetes, when you first probably learned about diabetes, what are some of the signs and symptoms of diabetes? Do you remember polyuria, polydipsia, polyphagia? So because of high blood sugar levels, often people who have diabetes will urinate a lot to try to get rid of excess sugar levels. Well, the developing fetus will do the same. If you remember, the amniotic fluid is made of what? It's made of fetal urine. So in the same way, if the fetus is exposed to high blood sugar levels, it will have more urine, causing polyhydramnios, high amniotic fluid levels. In addition, women with diabetes are at greater risk for hypertension during their pregnancy. They're also at greater risk for dystocia, or having difficult labor, because of cephalopelvic disproportion. These babies are not diabetic, so they are producing insulin levels just fine in most cases. So they will store the glucose and become larger, making difficult labor. The developing fetus is also affected by diabetes. These fetuses are at higher risk for fetal death related to acidosis. In addition, they have greater rates of congenital anomalies, and this is thought to be due to increased glucose levels early on in pregnancy. In addition, they may be large for gestational age or macrosomic. This is because they're being subjected to greater levels of blood sugar levels, and they are storing this as excess fat and weight. If there's vascular disease present, vascular disease related to the settling of sugars within the vasculature, the fetus may have intrauterine growth restriction. So this would be the opposite of large for gestational age. So large for gestational age, they would be packing on the sugar as excess fat. Intrauterine growth restriction would be due to vascular disease, the settling of the sugar, so that the baby cannot get the nutrients that it needs because the vasculature and the placenta and so forth is affected by those high blood sugar levels. So it may be growth restricted. The baby may be born with respiratory distress syndrome. There's some thought that increased blood sugar levels can affect the production of surfactant, which is necessary for lung compliance when a baby is born. These babies are at higher risk for hyperbilirubinemia, or high bilirubin levels, and they're also at greater risk for hypocalcemia, low calcium levels. So do we expect the baby of a mother with gestational diabetes to be small for gestational age or large for gestational age? Well, let's think about this. We have high blood glucose levels from the mother. She has a problem producing insulin, so she has high blood sugar levels circulating. The baby then brings in extra glucose. It is not diabetic, so it will put on extra weight. This then would make the baby in many cases large for gestational age. This can also lead to difficult labor or cephalopelvic disproportion. The baby can be too big for the mother's pelvis. So in many of these cases where you hear wild things on the news of a 12 or 13-pound baby, many of these cases are the products of gestational diabetes. In addition, what do you expect the blood glucose level of one of these babies to be, high or low? Now this is a little bit counterintuitive. After the baby is born, we are concerned that the baby will have a low blood glucose level. Why? Again, the baby is not diabetic. It is producing high levels of insulin to deal with high blood sugar levels that it's getting through the maternal blood from the glucose being transferred in the placenta. So it's making these high insulin levels. When its supply is cut off, when it's born, the cord is cut, its glucose supply is cut off. What's going to happen? Its sugar is then going to bottom out. So we are concerned about low blood sugar levels in the babies of gestational diabetic mothers. In addition, they are often large for gestational age. So let's consider insulin requirements during pregnancy of a patient who has diabetes mellitus. Early on in pregnancy, insulin needs typically decrease. Later in pregnancy, insulin needs typically greatly increase. They can double or quadruple what they were previous. And postpartum, insulin needs dramatically decrease as the placenta gives way. Which patients are at risk for gestational diabetes? We will screen them all, but certainly we want to be cognizant of a few things as we're looking over a patient's health history and assessment. Women who have signs of diabetes. What would these be? Certainly hyperglycemia is one of them. Also, glucosuria, so if they are spilling glucose in their urine, and or obesity. If they have a family history of diabetes or gestational diabetes, a prior delivery of a large for gestational age baby may be a hint that they were diabetic in the past and perhaps undiagnosed. Also, a previous fetal demise, since patients who are gestational diabetics have greater incidence of fetal demise. Patients with gestational diabetes often have a nursing diagnosis of actual or potential knowledge deficit related to their disease. What can we do as nurses? What can we teach them to help them through this? Certainly we want to encourage them to maintain an ADA diet. This would be a low-carb diet, often sustaining carbohydrates and proteins. And we also often have them count calories, and this would be an order provided by their provider or the dietitian. We also encourage them to regularly exercise and monitor their glucose. Again, this would be parameters set by the provider. Often it is a fasting and a 2-hour postprandial, meaning they would test their blood sugar first thing in the morning when they've been fasting and then 2 hours after eating. Medications can also be ordered if they cannot adequately maintain their desired blood glucose levels with just diet alone. These can include insulin. This can be either be long-acting, short-acting, or a mixture of both, or oral agents. Sometimes patients also have a sliding scale, so the amount and type of insulin depends on what their blood sugar result was. So there's a fair amount of education that goes along with this so that the patient can understand what's happening within their body, accurately interpret their glucose monitoring, and then self-administer. Most of these patients are at home. They can be seen and come in and be admitted for gestational diabetes if it really gets out of control, but for the most part, the hope is that we can manage them and have them manage themselves and teach them to manage themselves. As far as monitoring the baby is concerned, fetal kick counts are often ordered for the patient to do on their own. The presence of fetal movement is a great indicator of fetal well-being. So certainly, since they are at risk for increased fetal death and other problems, we do want to keep a closer eye on the fetus for these patients. At home, if they aren't being monitored by the provider in the hospital setting, fetal movement is a great indicator that the baby is doing well with the presence of it. Now that you have a good understanding of the physiology of diabetes as a pregestational issue or diabetes as a gestational problem and how it can affect both the mother and baby, you probably realize that it's very important that we assess the diabetic patient throughout her pregnancy. Much of this can happen prior to knowing potentially that the patient is diabetic. We want to get a good baseline of what her height and weight are so that we can determine if she is in excess or inadequately gaining weight. Also, early evaluation of a pregnancy and its dates and gestational age are great indicators for these patients of what the true gestational age of this pregnancy is. As we've discussed, these fetuses are at risk for being large for gestational age and occasionally intrauterine growth restricted. So it's very important that we get an early evaluation so that we know the true gestational age. Later on, if we get it, we can get a falsely heightened or lowered gestational age. In addition, we want to assess for neuropathy and the possibility of infection, since these patients who are diabetic are at greater risk for both of these. We also expect to assess the fetus. How is it coping with the mother being diabetic? Certainly, the presence of fetal movement is a great indicator of fetal well-being. We'll also expect an order for a non-stress test, some monitoring, possibly a biophysical profile, where an ultrasonographer would look for signs of fetal well-being within the ultrasound, accompanied by the non-stress test. And we would expect ultrasound to make sure that there aren't any other risk factors, such as congenital anomalies, such as being large for gestational age or growth restricted. So it's important that we assess both the mother and the fetus when the mother is a diabetic. In reviewing gestational diabetes, as we conclude with it, I just want to review some things about the mother and the newborn or fetus. Is this a chronic condition or a condition of pregnancy? The answer is it can be either. What are risk factors associated with gestational diabetes? What do you think they might be? Well, they can certainly be a family history of this. Also, if she's had prior children, what might you want to ask? Their weights. This may give some indications possibly of having undiagnosed gestational diabetes if she's had a history of babies who are large for gestational age. Not always, but it might be making a bell sound in your mind if she tells you she's had several deliveries and they were all large for gestational age. What is a mother diagnosed with gestational diabetes at risk for later in her adult life? This is type 2 diabetes she's at risk for. And also remember that gestational diabetes aids in vascular disease. On the side of the baby, is the baby a diabetic? No, not necessarily. So are we concerned about the newborn having high or low blood sugar? We just said that the baby is not a diabetic, so when we cut off that blood supply containing high blood glucose levels, what's going to happen? We're concerned about the baby having a low blood sugar. And then do you expect the newborn of a diabetic mother to be average for gestational age, large for gestational age, or small for gestational age? We're concerned that the baby, in many cases, cases, is going to be large for gestational age because it's not a diabetic. It is packing on those glucose levels as fat. Note that there are cases when there's vascular disease where this can cause intrauterine growth restriction, but it is far more common for a newborn of a baby born to a gestational diabetic mother to be large for gestational age. So these are some important considerations just to sum things up about both the mother and the newborn. Anemia is another issue that can be a pregestational issue that can affect pregnancy. There are generally two types: those with insufficient hemoglobin production and those with hemoglobin destruction. As far as the insufficient hemoglobin production is concerned, this is generally related to nutritional deficiency. Deficiency of what? Iron deficiency and folate deficiency. Generally, when patients get pregnant, you'll see them prescribed an order for a prenatal vitamin and also folic acid. What can the deficiency of folic acid be connected to? The answer is it can be connected to an increased incidence of neural tube defects within the newborn. Moving on to hemoglobin destruction, this is often related to inherited disorders. An example of this would be sickle cell anemia. Iron deficiency anemia can affect both the mother and the developing fetus. As far as complications for the mom are concerned, this can lead to infections, fatigue because they have less ability to carry oxygen, can be related to preeclampsia, and then of course they tolerate blood loss poorly. And we expect that the mother, when she delivers, is going to probably lose some blood, so they don't tolerate this as well. As far as the baby is concerned, iron deficiency anemic mothers often have fetuses who can be low birth weight. They can deliver them preterm. This means delivery prior to 38 weeks gestation. They're at greater risk for fetal demise and then neonatal death also. How do we prevent this? We prevent this by prescribing prenatal vitamins. And in cases when we know that the woman is iron deficient, they will often order 60 to 100 milligrams of iron per day and encourage patients to eat an iron-rich diet. The other type of anemia related to a nutritional deficit is megoblastic anemia, or folate deficiency. As far as the mother is concerned, she may present with nausea and vomiting or anorexia. On the end of the fetus, this can be associated with open neural tube defects. And how do we prevent this? Women are prescribed 0.4 milligrams of folate per day, or 1 milligram of folate plus an iron supplement. Sickle cell anemia is an inherited disorder. It is not related to a nutritional deficit. Who is at risk for this? Generally, it is the African American population who's at risk for sickle cell anemia. Symptoms include abdominal and joint pain. Here we have the cells actually sickling. You see, looking at the picture, what a normal red blood cell looks like and then what a sickled cell looks like. So it takes on that sickled appearance, and this can really cause a lot of pain, particularly abdominal pain and joint pain. Complications can include infection, congestive heart failure, and renal failure. It's really important that these patients get prompt treatment of infections and are hospitalized during crisis. Often during crisis, their management would include transfusions and pain management. As far as the fetus is concerned, these babies are at increased risk for fetal death, prematurity, and intrauterine growth restriction. Thalassemia is an autosomal recessive disorder where abnormal hemoglobin is made and there's a resulting excessive breakdown of red blood cells. This can lead to a large liver and spleen. Bony formations may also be present. Who is at risk? This is more of a condition that affects those from around the Mediterranean, those from Greece, Italy, and China. Treatment includes folic acid, transfusions, and chelation, What is chelation? Well, we have an excessive amount of red blood cells breaking down, leaving large iron levels behind. Chelation is the removal of that metal, in this case the removal of iron. The iron levels can get so high that they can actually lead to death. Without treatment, it's unusual for a person to live past 20 or 30 years old. A woman who has heart disease may also be at greater risk during pregnancy. If she had a congenital heart problem, this means that she was born with a problem such as tetralogy of Fallot or a septal defect. If this was repaired successfully, we would expect an order for antibiotics to prevent any infection. However, if she does have cyanosis with this, whether her defect was repaired or not, she and the fetus are at greater risk. Mitral valve prolapse is a cardiac issue that's not all that uncommon with our patient population. Here, the mitral valve leaflets prolapse into the left atrium, and this can result in regurgitation of the blood. Generally, this is asymptomatic. Sometimes patients will have palpitations, and we'll recommend that they have decreased caffeine intake in their diets if this is the case. Generally, however, it's asymptomatic. This is often treated with Inderal. Peripartum cardiomyopathy, as the name suggests, is when there is a problem heart-related that happens during the peripartum period, during pregnancy or shortly after delivery. In this case, with peripartum cardiomyopathy, there is a left ventricular dysfunction, and this happens in a woman who's had no history of heart disease prior to the pregnancy. It typically occurs during the later half of pregnancy to the early postpartum period. Symptoms of peripartum cardiomyopathy include chest pain, dyspnea, which is difficulty breathing, orthopnea. What is this? Orthopnea is positional breathing. So a woman may have to sit up to breathe or state that she's sitting in a recliner to breathe as she sleeps. She can also be weak or have edema related to this. How is a patient with heart disease typically managed during labor? Well, the answer depends on the severity of her cardiac disease and what kind of limitations she has related to it. If she has no or slight limitations due to her heart disease, we would encourage that she go into labor naturally, and we would observe her very closely because she still may have a change during labor, so we will observe her closely. Depending on the severity, if she does have limitations, you may see them limit pushing in these patients. So you may see them let her labor down, is a term. Let the contractions do the work, bring the baby down. Then when the baby is very low, with some anesthesia, they would deliver the baby via forceps or vacuum extraction to limit pushing. Also, we want to make sure that patients with heart disease have decreased pain and decreased anxiety because these can increase stress to the heart. But the laboring process is stressful to the heart even of a normal healthy patient. So the patient who has heart disease, we do need to keep careful consideration of this, monitor them closely. In addition to the pre-gestational issues that made pregnancies high risk that we've just discussed, there can be gestational onset problems that can make for a high-risk pregnancy. A spontaneous abortion is what many lay people refer to as a miscarriage, the loss of a pregnancy prior to 20 weeks gestation. There are several classifications. A threatened abortion is unexplained bleeding, cramping, the cervix is still closed, and we're worried that there's a threat of abortion, a threat of the loss of pregnancy. It should be noted that about 20 or 25% of pregnancies do have bleeding during the first trimester, and about half of these will result in a miscarriage. What is an imminent abortion? As the name suggests, she is imminently going to have a miscarriage. Here she has increased bleeding and cramping, the cervix may start to dilate, her membranes will rupture. This is an inevitable abortion scenario. An incomplete abortion is where parts of the products of conception are retained. Most frequently, this is the placenta. So she delivers or miscarries some of the pregnancy, but it's incomplete. Some is still retained. A complete abortion is where all products of conception are expelled. And a missed abortion is where the fetus dies in utero, but it is not expelled at all. So we would note decreased growth in uterine size, and changes in the pregnancy begin to regress. What are some of the nursing considerations for a patient who's going through a miscarriage or spontaneous abortion? Certainly, we've talked about bleeding with these, so we would want to make sure that physiologically she's stable. In addition, the patient may be in a state where she's very fearful, especially in cases where there's a threatened abortion. She may have acute pain because she would often have cramping associated with this process. And then, of course, grief related to the expected loss. An ectopic pregnancy is when a pregnancy implants outside of the uterus. For our discussions, the most common place that this would happen is in the fallopian tube. Certainly, these diagrams show a lot of other places where this can happen, but the most common place is in the fallopian tube. This would not be a viable pregnancy. In the fallopian or tubal pregnancy, the ectopic is often called when it happens in the fallopian tube, the woman kind of has two losses. One is the loss of this pregnancy, because it wouldn't be able to be viable and completely grow within the fallopian tube. The other is the loss of that tube. So often they need to go in and remove the portion of the tube where the pregnancy is. And we know that a woman cycles and ovulates from each side. So we are in essence taking half of her fertility away by going through this. So the woman who has an ectopic pregnancy, like I said, most often in the fallopian tube, can go through two losses. One is for this pregnancy because it's not viable, and the other is for her loss of some of her fertility. As you can see, like I said, an ectopic pregnancy really means a pregnancy that implants outside of the uterus, so it can happen in more places. More often than not, though, it does take place in the fallopian tube. A hydratiform molar pregnancy is characterized by gestational trophoblastic disease. This is where the trophoblasts, or the outermost layer of the embryonic cells that give rise to the chorion, replicate and proliferate abnormally. This in no way resembles a viable pregnancy, but instead grape-like clusters, as you can see in the picture, of kind of placental tissue. This can be really difficult for mothers because there's a loss of the potential pregnancy here, and there's also a rare but still possible risk for a type of cancer related to this, and that's called choriosarcoma. So these patients, we do need to be very supportive of them. Hyperemesis refers to nausea and vomiting that are so severe that they affect hydration and the nutritional status of the woman. Typically, you'll see these patients lose at least 5% of their body weight. So, as we've discussed, some nausea and vomiting is normal. However, hyperemesis is when it's so severe that it really does affect hydration and nutritional status. What causes this? Well, we're really not quite sure. There is some thought that hyperemesis and nausea and vomiting related to pregnancy have to do with HCG, human chorionic gonadotropin. What is the goal as we're helping patients who have hyperemesis? The goal is to control nausea and vomiting, to correct fluid and electrolyte imbalance, and promote adequate nutrition. So to do this, typically we'll see some medications used to help control nausea and vomiting. These can include B6, the vitamin B6, Phenergan, Reglan, or Zofran. We want to control the nausea vomiting so that they can adequately eat. Sometimes you'll see a diet plan ordered once the nausea and vomiting ceases, and this may be the BRAT diet, B-R-A-T, and each letter in this acronym stands for a type of food. So in the BRAT diet, include bananas, rice, applesauce, and toast. So kind of like after the flu, we're going to start them out blandly. As far as the fluid and electrolyte imbalance is concerned, if they are hospitalized for this, typically we would see an IV for some hydration. If we are not able to adequately control nausea and vomiting and get them on the right track for nutrition, we may see an order for TPN, total parenteral nutrition. where a substance with all of the broken down nutrients, minerals that are required are then given intravenously to the patient. This would be in most severe cases. Next, we'll discuss preeclampsia and eclampsia. Preeclampsia is an increase in blood pressure in a previously normotensive woman after 20 weeks gestation. Also with this, in diagnosing it, there is protein in the urine. Note this is gestational hypertension. So again, this is a phenomenon of pregnancy. And the etiology, what causes this, isn't really well understood. There are some theories out there, but we're not all that sure what causes this. But it is a problem of pregnancy, and the only real cure for it is delivery of the baby. So preeclampsia is the increase in blood pressure after 20 weeks. What is eclampsia? Eclampsia is when she actually has a seizure. So she's pre-eclamptic, pre-seizure. Once she seizes, she is then considered eclamptic. So our goal in the pre-eclamptic patient is to prevent seizures, prevent her from becoming eclamptic. So how does preeclampsia and this gestational hypertension affect the pregnancy and the woman's body? As far as the pregnancy is concerned, there's decreased uteroplacental perfusion. What does this mean? Well, if there's decreased perfusion to the placenta and uterus, there is lacking the ability to exchange nutrients and oxygen. So what we might see is a baby who is IUGR, intrauterine growth restricted, so it would be smaller. In addition, there's decreased hepatic perfusion to the liver. So what would you expect to see on labs regarding the liver enzymes? We would expect to see that there may be elevations in ALT and AST. Those are the liver enzymes. In addition, she might have some right upper quadrant pain related to the decrease in flow to this area and obstructed flow to the liver. She will also have decreased renal perfusion. Therefore, we may see protein in the urine. And how do you think the BUN and creatinine would be affected? These may be elevated, so she may have an elevation or increase in BUN and creatinine related to this. In addition, if she has decreased renal perfusion, what do you expect to see? Perhaps some edema. This isn't really a telltale sign, though, because it is normal to have some edema even with the normal pregnancy. However, we are concerned about this fluid building up in the lungs, being pulmonary edema. Also cerebral edema, edema to the brain. And how do you think all of this might affect her platelets? The vascular damage can lead to platelet aggregation, which can lead to a low platelet count. I'm including this visual for the visual learners who are out there in the group. If you prefer, rather than the prior explanation of what's going on related to vascular damage and decreased perfusion to all of the body systems, you can look at this and kind of work through the process here, seeing that there can be intrauterine growth restriction, low platelets, elevated liver enzymes, right epigastric pain, decreased serum albumin and how that can cause some swelling and edema, along with decreased renal perfusion that can cause increased BUN and creatinine, protein in the urine, also edema. And then these things can relate to hypertension, generalized edema, retinal edema, pulmonary edema, and cerebral edema. If you aren't a visual learning type of person, or this looks overwhelming to you, go ahead and use the prior explanation. But they are the same. I just thought I would include this as another way of kind of looking at the preeclamptic process. When caring for the woman with preeclampsia, our nursing assessment will be quite thorough. Of course, we'll be monitoring her blood pressure, temp, and respirations. We'll also be assessing the fetal heart rate. How is the fetus responding to this high blood pressure and potential decrease in perfusion? We'll be asking her if she has any vaginal bleeding. What are we looking for here? We're looking for the potential for placental separation. Also, does she have a headache from the high blood pressure from the cerebral edema? Does she have any visual changes? Sometimes women will see spots before they have a seizure. Does she have any right upper quadrant pain or epigastric pain? The right upper quadrant pain could be due to changes within the blood flow and circulation to this area, to the liver. We'll assess her deep tendon reflexes. If she's hyperreflexic, she may be in a state where she's getting close to having a seizure. We'll also assess clonus. What is clonus? We will push her feet back. If you think of kind of how we would do a Homan sign, we'll push her feet back. And upon letting go, normally a patient would just relax their feet. If they have positive clonus, the feet will kind of shudder down. And we would count the number of beats if clonus is present. We'll also assess edema. Edema isn't always a telltale sign of preeclampsia because some edema is normal within even the normal pregnancy. However, in this case, since there's decreased perfusion, she may have more edema. In addition, possibly the presence of pulmonary edema or fluid collecting in the lungs. What would this type of patient look like? Perhaps she would have chest pain, shortness of breath, dyspnea, shallow respirations. We'll also assess for decreased urinary output and protein in the urine. We would expect some labs to be ordered pertaining to BUN, creatinine, liver enzymes, potentially platelets so that we could be assessing for HELLP syndrome also. And then we'll be assessing her level of consciousness. It's not uncommon for a woman getting close to having a seizure to become very irritable. A woman is considered eclamptic once she has a seizure. So what are your nursing assessments and interventions? Certainly you would want to assess the body involvement, how much of her body is involved, and is she incontinent during this? The duration of the seizure activity, how long it lasts, and the fetal status related to this. If she's on the monitor, we want to see how the baby's heart rate is responding to this and the patterns of the baby's heart rate. If she's not, we should be getting a Doppler to assess fetal heart tones or asking for an ultrasound. In addition, we want to prevent maternal injury, so we could pad side rails ahead of time, position the patient to her side also to prevent aspiration. During this, we want to make sure that she is breathing and oxygenated as well. HELLP syndrome can be associated with severe preeclampsia. HELLP syndrome stands for hemolysis because we have the breakdown of blood cells, the vascular damage. EL stands for elevated liver enzymes because we have the decreased perfusion to the liver. And then LP stands for low platelets. Platelets would be less than 100,000. So this is HELLP syndrome. Symptoms that the patient might experience include nausea and vomiting, malaise, flu-like symptoms, and epigastric pain. When caring for a patient who has severe preeclampsia, the goal is to prevent seizures or convulsions, prevent liver and kidney disease since we know that there's decreased perfusion to these and the labs may be indicating that, and to maintain the pregnancy. We would expect to provide her with an environment where she has decreased stimulation, oftentimes bed rest with this too. Often magnesium sulfate is ordered because it's a CNS depressant. So this is used to prevent seizure activity. Magnesium sulfate. What is the antidote to magnesium? Sodium and potassium work together. What works with magnesium? What would the antidote to magnesium sulfate be? The antidote is calcium gluconate. So we always want to have calcium gluconate at the bedside for patients who are on magnesium sulfate therapy. In case they become mag-toxic, we want to have the antidote to it there. Also, we would expect an order for corticosteroids for several reasons. One of them is fetal lung development. We give betamethasone IM, typically 2 injections of this. Oftentimes, patients with severe preeclampsia will deliver early. It's kind of an on-the-fence sort of game with maintaining the pregnancy. Should we maintain the pregnancy, but the pregnancy is what's causing the preeclampsia, or should we deliver early? Because what's the only cure for preeclampsia? The only cure is delivery of the infant in placenta. So we want the baby to be mature, particularly concerned about its lung development so that it can breathe independently when it's born, but we're also concerned about the mother's well-being. So we kind of fence that a little bit and determine, what are her labs doing, how are her blood pressures doing, and looking at the fetal development at the same time. The other reason corticosteroids would be used is for women who have developed HELLP syndrome. In addition, we may see an order for antihypertensive, so we can bring down her blood pressure and hopefully with the prevention of a stroke. As stated, magnesium sulfate is often used in severe preeclampsia to help prevent seizures because it's a CNS depressant. What does the typical order look like? Typically, there would be a loading dose, or a bolus. This means a large amount given over a small period of time. This loading dose would be 6 grams, or a bolus of 6 grams given over 20 to 30 minutes. After this, we give a maintenance dose. What is she going to be on after the loading dose or bolus? The maintenance dose is 2 to 3 grams per hour. Again, what is the antidote to magnesium sulfate if you believe that she may be mag toxic? The antidote is calcium gluconate. What are some side effects from the magnesium sulfate, or what might indicate that she may be getting mag toxic? Certainly common side effects would be flushing or feeling very warm. Typically they'll say, I'm hot. Their skin might look flushed. They might be throwing the blankets off the bed. A headache or some blurred vision can kind of interfere with their sensorium a little bit. Some lethargy, because it is a CNS depressant. And we also want to be aware that there could be some pulmonary edema. So if it's a CNS depressant, they aren't breathing as deeply, and they have fluids, they may start to get into a pulmonary edema situation. There's some special nursing considerations for the patient who is on magnesium sulfate. Interestingly, we'll be assessing some of these same things because the patient is preeclamptic. With the magnesium assessment, we'll be looking at these issues, but for a little bit of a different reason. With the mag sulfate assessment, we'll be looking for headache. This time not for cerebral edema or from the pressure pounding on the brain, but is the magnesium level too high, giving her a headache? Also visual changes. This time, we're not looking to see if she could be about to have a seizure because she's seeing spots, but this time we're looking to see if she's having that blurred vision due to high levels of magnesium. We'll also be looking at deep tendon reflexes. With the patient who's preeclamptic, we considered DTRs, deep tendon reflexes, because we were worried that she would be hyperreflexic, possibly indicating potential seizure activity. This time we're going to look for diminished deep tendon reflexes. Is the magnesium just too much? In addition, we'll be looking for chest pain and shortness of breath. These can be related to respiratory compromise from the magnesium, and also may be signs of pulmonary edema. We'll also want to be looking at her arousal state this time, not for irritability, indicating the preeclampsia and possibility of seizure activity, but this time decreased arousal. During Rh alloimmunization, this diagram should look familiar to you. What's happening here is that a mother has been exposed to Rh positive blood when she is Rh negative during a prior pregnancy. The blood mixes and the mother makes antibodies to Rh positive blood. With the subsequent pregnancy, she can then attack that baby's blood cells. This is Rh alloimmunization. This is a concern only to women who are Rh negative. This conversation about Rh alloimmunization becomes more complex, and we'll get into it in more detail here, assuming that there has been mixing. Okay, this is a high-risk situation now. Erythroblastosis fetalis is severe hemolytic disease of the fetus and newborn. We may see on ultrasound hydrops fetalis. The baby becomes extremely edematous related to this anemia associated with the breakdown of its red blood cells. In addition, the fetus could go into congestive heart failure. Once born, we can see hyperbilirubinemia or jaundice. Some of these kids are so sick when they're actually born yellowed already, way prior to the 24-hour mark where we would typically be assessing. And I mentioned before the term kernicterus. This would be where the bilirubin levels get so high that they settle in the brain, causing permanent and irreversible brain damage. But here, during the pregnancy where we know that Rh sensitization has taken place, we'll be monitoring for high drops and erythroblastosis fetalis. There are a couple of tests we can do to see if the newborn or mother have been sensitized. The direct Coombs test is when we directly test the newborn to see if it has been sensitized to the antibody that the mother has produced against its positive blood type. The indirect Coombs test is where we're indirectly testing, so we're testing the mother's blood in this case for sensitization. A negative means that there's been no sensitization, so her antibodies haven't become active, meaning she hasn't been exposed to great amounts of the fetal Rh positive blood, and then hopefully its cells have then not been attacked. So a negative Coombs test is what we're hoping for. Positive would mean that there was some sensitization. In cases where there was mixing of the blood, if there was an abruption or something like this, a Kleihauer-Becky test estimates the extent of bleeding, so this can give us a better idea as to how much RhoGAM, or Rh immunoglobulin, we should administer based on the amount of bleeding or mixing of the blood. ABO incompatibility can also be an issue. So we're all either A, B, O, or AB in blood type. So we've talked a lot about Rh sensitization. There can also be ABO incompatibility. Think about this the way you would think about it with a transfusion. So if a mother is type O and a fetus is type A or B, there can be an issue here if she's exposed to the type A or B blood. Anti-A and anti-B antibodies are naturally occurring, so this is not like Rh sensitization where her body is exposed to one pregnancy of the opposite type and responds by making an antibody. Instead, these antibodies are naturally occurring. So this may affect the first pregnancy. These newborns may have mild anemia, and we will assess them for jaundice. Typically, though, these are not life-threatening kinds of situations the way Rh sensitivity could be. As we move on and discuss age as a factor of pregnancy, teen pregnancy and advanced maternal age pregnancies are high risk, so we'll begin talking about teen pregnancy. To start this, we're going to look at an overview of adolescence and the physical, psychosocial development during this time. Physically, we have the time of puberty occurring. This includes menarche, which is a girl's first period. This typically happens between 12 and 13 years of age, although this can vary. These girls can go through weight changes and also have a growth spurt. Psychosocially, they're kind of trying on many hats as they go through adolescence, looking at what their identity is, who they want to be, what they think they are, where they fit into things. Also, they may go through periods where they're seeking autonomy and independence, wanting to make their own decisions. Developing intimacy in relationships. This could be with peer relationships, developing closeness. You might see passing notes or notebooks or best friends, those kinds of things. And also potentially starting to have interest in boys or getting into relationships that way. They're becoming comfortable with their own sexuality. Prior to puberty, many children are pretty asexual. It doesn't really occur to them what's going on now. The growing woman has developing breasts and pubic hair. She's starting her period, which can be, a big deal and scary or embarrassing to some. So becoming comfortable with all of that and becoming comfortable taking care of the body and the needs that come along with those things. Also, many times they have a sense of achievement. This is when they can start to make some decisions independently. They can start to feel like they're growing up or grown up and want to take on independence. So a sense of achievement is often there for girls and adolescents as they go through this time period. It's really important that we embrace the good qualities within all of this so that they have a great foundation as an adult. In the literature, there are several factors that contribute to adolescent pregnancy and engaging in sex. One of these is lack of foresight. So they feel that it won't happen to them or can't look to the future, what holds in the future beyond today or right now. In addition, there's often peer pressure. I did this and it's really cool. Sex is popular in TV, music, on the internet. In addition, rates are higher among teens having sex if there's family dysfunction. In some of these cases, even, girls may plan for a teen pregnancy. Some of them may say, I want somebody to love, somebody that will love me, and may plan for a pregnancy. If girls are sexually active at a very, very young adolescent age, it is important that we rule out an incestuous relationship if she is very young and the partner is much older. This graph can show us a few different things as it pertains to teen pregnancy. Here we see the rate of pregnancy per 1,000 women. So you can see over time, the 18 to 19-year-old population has higher pregnancy rates than the 15 to 17-year-old population does. There were higher rates of pregnancy in the 70s, they declined toward the 80s and 90s, and we saw a spike again among all age groups, and then we're currently declining. Note that in the 1970s, there were approximately 110 out of 1,000 women in that 18 to 19-year-old age range who were pregnant. In the 2000s, we're seeing that rate among 18 to 19-year-olds at about 80 women being pregnant out of 1,000. As we look at teen pregnancy, it's important to understand, why do teens have sex? So there are a variety of schools of thought out there about abstinence-only education or sex education. But what's really at the core of this? Why are teens having sex? About 61% of girls say that their partner is pressuring them, and that they think that they're ready to have sex is also up near 60%. Girls also, about 45%, say they want to be loved. And curiosity for boys and girls, both around 40%, along with wanting to be popular. Then we start seeing the reasons for boys stream ahead. They don't want to be teased about being a virgin. This is a bigger indicator for boys than it is girls. Movies and TV make it seem normal for teens to have sex. Again, higher for boys. And then someone forcing them to have sex. About 25% of girls say that that's the case. So the leading number for girls would be that their partner is pressuring them to have sex. The leading number for boys is that they think that they're ready to have sex. So it's just interesting to consider the factors why teens have sex. Teen pregnancy poses several physiological risks to both the mother and developing fetus and newborn. Many teens don't follow through on prenatal care. Initially, they may be in denial about the pregnancy or scared to tell anybody. Often they first tell their friends. However, it is often the teen's mother, so the newborn's grandmother, who is most supportive to her throughout the pregnancy and after the delivery. They're at greater risk because they smoke more frequently. There's a higher incidence of sexually transmitted infections. In addition, teens are at much greater risk for developing preeclampsia. As far as the baby is concerned, they're at greater risk for a preterm birth, a low birth weight, and cephalopelvic disproportion. We'll mention cephalopelvic disproportion several times. If you recall, this means that the baby's head and body and the maternal pelvis aren't a good fit. So if it's a young woman who's still developing, her pelvis may be small, leading to cephalopelvic disproportion. There are psychological risks to both the mother and newborn of a teen pregnancy. Certainly having a baby will interrupt the woman's own development. She's a young woman who's developing, looking for autonomy and independence, figuring out who she is, and those are normal developmental pieces here. However, having a baby can impede some of that. Some of these girls do a very nice job. However, others do need help meeting their own developmental milestones. For example, you might want to be a good role model or potentially get social service involved. If you come across a situation where maybe a baby is really crying and crying and crying, and you go in the hospital room and see if you can be of assistance, and the young woman's in the bed while the baby is in the crib crying. And you ask if you can be of help, and she said, yes, the baby's crying, but I'm in too much pain. Assuming she's not in physiological harm, there comes a point where you need to role model, kind of trying to be able to put yourself aside to care for somebody else and care for and meet the needs of the baby. When discussing teen pregnancy, the role of the father is an integral piece. Adolescent males tend to be sexually active at a younger age than their female counterparts. About 66% of those males who impregnate a teen girl are older than the age of 20. So these are not adolescents having sex with each other in many cases. Relationships between the teen mother and father of the baby have lower rates of longevity and success. If they do marry, divorce many times is the outcome. However, nurses should act to support the father who wants to be involved and take an active role, whether this is an active role in the child's life, financially, or both, but we should be supportive to the father. Considering the other end of the spectrum, advanced maternal age is when a woman is pregnant and delivers after age 35. There are many contributing factors to this increase in the number of advanced maternal age patients we're seeing. Many women are attending college now and pursuing a career. They may wait to get married and wait to have children. In addition, there are more birth control options that are available, and they're very effective. The high cost of living prevents some people who are financially prudent from having children earlier. And in addition, reproductive technology and the improvements and increases in it allow couples to have children who maybe in the past wouldn't have been able to have children at all. So there are some advantages associated with this and some disadvantages associated with having a child at an advanced age. We'll be discussing these in the slides to come. What are some of the medical risks of advanced maternal age, having a baby when the woman is older? Certainly, if she's older, she has a higher incidence of chronic underlying medical conditions already. So these can put her at greater risk during the pregnancy, as we've discussed during high-risk pregnancy. She has a greater incidence of diabetes and hypertension, as well as placenta previa. She may have dystocia. This is difficulty during labor. In addition, women who are older have an increased incidence of miscarriage and genetic issues, commonly Down syndrome, so we would monitor these patients very carefully, especially during the start of the pregnancy. Infants from these pregnancies may be born preterm and may be low birth weight. There are some special social implications for the couple who's of advanced age having a baby. They might ask, will I have the energy to chase around this child? If they're 40 years old when they have a baby, which isn't all that uncommon anymore, they would be 58 when that child graduates from high school. Along with this, there are financial implications. At about the same time that child would be going to college, presenting a large expense, the parents would presumably be trying to retire. So financially, this can be difficult to balance both out. They may also feel socially isolated or alone. Their counterparts of the same age may not have young children socially isolating them, and those at school functions and that kind of thing are typically younger than they are. So these parents may feel that they are socially isolated. It's important that we assess not only the mother, but the fetus during the high-risk pregnancy. Now we'll discuss several mechanisms for assessing fetal well-being during the high-risk pregnancy. What conditions and factors would indicate need for further fetal assessment? Maternal conditions such as hypertension can certainly affect the pregnancy, as can diabetes. If she has renal disease or heart disease, particularly if she has cyanosis associated with the heart disease. If she has poorly controlled hyperthyroidism or hemoglobinopathies. As far as prenatal factors are concerned, if she's preeclamptic or states that she has decreased fetal movement, we would want to look into this more. If she has low amniotic fluids, that would be oligohydramnios, or a great amount of amniotic fluid, hydramnios, we would want to do further assessment. Why? We know that the Fluid cushions the cord, and there can be indications or there can be anomalies causing these things. If there's intrauterine growth restriction, if the pregnancy is post-term, if there's isoimmunization or Rh incompatibility, we want to see that the fetus is okay, that the mother's body and its antibodies against the Rh positive blood are not attacking the Rh positive blood of the fetus. If the mother has a history of a prior demise, if there are multiples in this pregnancy, or multiple gestation, if there are known fetal anomalies or abnormal test results, all of these would be indications for doing further fetal assessment. The presence of fetal movement or assessing fetal kick counts indicates fetal oxygenation and that the central nervous system is intact. This is a non-invasive procedure. The woman does this at home while lying on her side quietly, and it's cost-effective. It doesn't cost anything. So we recommend that the woman does this at the same time every day, and that she does this at about 1 hour after eating meals, so that the glucose has enough time to make its way to the fetus and it's hopefully nice and active. We're going to ask her to count the number of fetal movements in 30 minutes and do this 3 times per day. There should be at least 3 movements in 30 minutes. When should she be concerned? If she doesn't feel this, 3 movements within 30 minutes, we're going to have her assess for another hour. She should be concerned if there are fewer than 10 movements in 3 hours anytime through the day. If overall the fetus's movement is slowing, or if she's not feeling the fetus move in the morning, these would be times when she should notify her provider for further evaluation. Use of the fetal monitor will be used in some of the following tests, so I want to take this opportunity to review. What is the normal fetal heart rate? We would expect the baseline to be somewhere between 110 and 160. Tachycardia, as the name indicates, is when the heart rate is above 160 beats per minute, and this would need to last at least 10 minutes. What we're trying to do here is differentiate between true tachycardia and the fetus having an acceleration, since tachycardia could be a sign of potential distress. It could be related to fetal hypoxia or asphyxia, anemia. A big one here, what do you suspect if the baby's heart rate is up? What would you suspect on the mom? It's potential for infection. Also, it could be a sign of prolonged fetal stimulation, but this is an abnormal finding, so we would want to let somebody know and monitor it closely. A bradycardia, on the other hand, what do you suspect this is? This is when the fetal heart rate is less than 110 beats per minute for at least 10 minutes. This also is an abnormal finding and can indicate fetal distress. This could be due to stimulation of the vagal nerve. This could be due to drugs. Some of them we even give, like anesthesia. Maternal hypotensive reactions. When might a mom have hypotension? If she gets an epidural, it could bottom her blood pressure out, and then we could see a following bradycardia. Prolonged umbilical cord compression, or hypoxemia or late asphyxia. We also need to rule out with a bradycardia that we aren't getting the mother's pulse. Occasionally, if we have an external abdominal fetal monitor on, it can pick up the maternal pulse. And if her pulse is, let's say, 80, it would pick that up, making us think that we have a fetal heart rate of 80. So the first thing we need to do is verify the finding. And then this is different from a deceleration because it's lasting at least 10 minutes. This is concern. What causes a late deceleration is a reminder. Do you remember? At the peak of the contraction, the heart rate starts to bottom out. This is due to uteroplacental insufficiency, and these are ominous. These are worth worrying about. What causes a variable deceleration? Variable decelerations are variable in timing. They have an abrupt onset, quickly down, quickly back up. What causes those? That is due to cord compression. These can become worrisome if they are severe and prolonged. What causes an early deceleration? In an early deceleration, the heart rate begins to go down early in the contraction. Therefore, it mirrors the contraction. What's this due to? This is due to head compression. Do we expect head compression with a vaginal delivery? We do. So if you see early decelerations and they haven't been there before, I would be thinking, well, she might be moving along. I would do an exam to see what her fetal station is and what her cervix is doing. The non-stress test is a very widely accepted test to determine fetal well-being. Here we'll put the woman on an external fetal monitor and observe for fetal heart rate accelerations with fetal movement. Typically we will monitor her for 20 minutes, although if we feel that the baby is having a sleep cycle, this can be up to 40 minutes. We'll give the mother a marker. She can typically push a button when she feels the baby move. And a normal finding is called a reactive NST. We say NST for non-stress test. So a normal finding is a reactive NST. This indicates that there are at least 2 accelerations that last at least 15 seconds that are at least 15 beats above baseline. So if the normal fetal heart rate is 140, we would expect the heart rate to go up to 155 for at least 15 seconds in duration, and we want this to happen at least twice within the monitoring period. A non-reactive NST is an abnormal finding. It would be non-reactive if the fetus lacked sufficient accelerations. If there weren't 2, if they didn't last 15 seconds in duration, or didn't go up at least 15 beats above baseline. This would indicate need for further monitoring. At least we would want to let the physician or midwife know if we found a non-reactive NST. Here we have an example of a non-stress test. What are the arrows pointing to? The arrows are pointing to accelerations. What would you first look at? When you look at this strip, we need to first determine what the normal baseline is for this fetus. And I would say that the fetal heart rate is around 130 for a baseline for this fetus. So we would want to see accelerations go up to about what number at least? It's 15 beats above baseline, so if we are saying that the fetal heart rate is hanging out at around 130 beats per minute, we would want to see that the fetal heart rate goes up to at least 145 beats per minute and stays there for at least 15 seconds. So in the cases where the pink arrows are, these are indicating times when the fetal heart rate accelerated 15 beats above baseline for at least 15 seconds. So what would the interpretation of this non-stress test be? Would this be reactive or non-reactive? This would be a reactive non-stress test. Is a reactive non-stress test reassuring or non-reassuring? This is reassuring. A reactive non-stress test is a normal finding. During a contraction stress test, the fetus is stressed with the presence of contractions, and we look at the fetal heart rate response to contractions. So in order to do this test, we must have 3 contractions that last at least 40 seconds in duration within 10 minutes. These can be spontaneous contractions, or they can be induced with Pitocin. So if we're giving her Pitocin to see how the fetus will respond to contractions, what is there a risk of? There's a risk of her going into labor. Even though we may not intentionally be putting her in labor, we may just want to see how the fetus responds to contractions. But there's a risk of putting her into labor if we give her some Pitocin. So what are the results? What are the possible results? A negative contraction stress test indicates that there are no significant decelerations that correspond with the contractions. A positive contraction stress test shows that there is a presence of late decelerations with at least 50% of contractions. So what is it that's reassuring? A negative contraction stress test or a positive contraction stress test? A negative contraction stress test is what's reassuring. Don't get confused and think that positive means good. No, positive means that there are late decelerations. That is not a good thing. The reassuring finding when it comes to a contraction stress test is a negative CST, negative contraction stress test. A biophysical profile includes a non-stress test and an ultrasound done by an ultrasonographer. It considers the presence of 5 factors. One of these is the non-stress test, where we're looking for fetal heart rate accelerations. The 4 other factors should be seen on the ultrasound, and the fetus is given 30 minutes to see these things. These include fetal breathing movements, fetal movement of extremities, fetal tone, and the volume of amniotic fluid. Each of these 5 points can be given a score of 2 for a possible high score of 10. Lower scores are associated with higher perinatal mortality and may indicate moving toward delivery. Of course, the lower the score, the higher the rate of associated perinatal mortality, and the more potentially emergent or urgent it would be to deliver the fetus. An amniocentesis is a procedure in which a needle is inserted through the maternal abdomen and into the uterus, where a small amount of amniotic fluid is aspirated. This is done under ultrasound guidance to make sure that the baby is not injured and also that the umbilical cord or placenta are not injured. The amniotic fluid is then tested for genetics because in the fluid are some cells from the fetus. So these cells then can be considered for their genetic makeup. In addition, the fluid can be looked at for its lung maturity, or the LS ratio for considering lung maturity. Rationale for testing genetics would include advanced maternal age, this would be age 35 years or greater, a family history of a birth defect, maybe they've had a child who was born previously with a birth defect, or an abnormal prenatal screening, such as a quad screen. Risks of amniocentesis are actually pretty rare, even though patients are often very anxious about this. Risks include cramping, possible leakage of fluid. There could be potential for fetal injury, but an ultrasound is used for needle guidance, so this is pretty rare. In addition, there is a slight chance of infection. There are higher rates of pregnancy loss associated with amniocentesis the earlier it is done. Percutaneous umbilical blood sampling is another test that we can do. This is often referred to as PUBS. This stands for, again, percutaneous umbilical blood sampling. With this is typically done in the operating room. A specimen of fetal blood is obtained percutaneously through entering the maternal abdomen and going in through the uterus. This is ultrasound guided, and a sample of blood is taken or aspirated from the umbilical cord. Why would we do this? There are certainly some risks involved. Penetrating the umbilical cord can allow for bleeding. And certainly this may put the woman into labor in addition, so there are some risks involved. Often this is performed to determine RH and blood type of the baby if we believe that potentially the fetus is RH negative and the mother is RH positive and potentially her body is having an isoimmunization reaction. Or if we're seeing high drops, collection of fluid on the baby that would be indicative of this. We might need to see what's going on prior to delivery even. And a PUBS, percutaneous umbilical blood sampling, is one of the methods of doing this. This concludes the high-risk pregnancy lecture. Following this, we'll be discussing pre-labor complications and then labor and birth complications.